Hello, everyone, and welcome to today's podcast, Workforce Health Literacy. I'm Seth Serxner, Chief Health Officer at EdLogix. I'm really pleased to have as my guest today Dr. Linda Anegawa. She's in a very busy space right now around obesity care, around all the issues of GLP-1s, and a lot more. Before we jump into the topic itself, introduce yourself and talk a little bit about your background and what you're doing these days.
Yeah, happy to, Seth. And thank you so much for having me. You're right. It is a very busy space. It's dynamic. It's rapidly evolving. And I think that's what I really love about it. So yeah, I'm Linda Anegawa by training. I'm boarded in internal medicine and obesity medicine and spent about a decade in academic primary care, loved teaching, loved the patients, but came to the realization that I just wasn't making patients metabolically better in the way that I always imagined that I would as a doctor. I'm just kind of slapping on all these different medications for chronic conditions, but never getting to the root cause. And so when I accidentally discovered obesity medicine 12, 13 years ago, while moonlighting in a bariatric practice, I was just blown away because I had never seen a person with type 2 diabetes come off insulin or an individual with sleep apnea come off their CPAP. It was just not something that even felt like it was possible. And that really turned the tide of my whole career into this space, as well as into the digital health space, because access was also an issue that I was concerned about, and just how we were going to reach all of the people in this country who needed care. So right now I'm the chief medical officer at Calibrate and formerly chief medical officer at Noom as well. And I live in beautiful Las Vegas, Nevada.
Just take a second. I don't want to get too commercial about it, but what's Calibrate's focus?
Yeah, so our focus is obesity care for employer populations. Our overall value prop is that Calibrate was really begun just as the wave of GLP-1 awareness and adoption was really starting. So the founders were very forward thinking in the way that they built the platform. They really purpose built it to be integrated and to adapt to each member in real time. It's not a bolt-on program to a wellness app or anything like that. It was fully integrated from the beginning, and the live coaches and the clinicians have this real-time continuous visibility in what's going on with the member, which is great because it just gives you a tremendous amount of adaptability. I mean, there's no one size that fits all on this journey. It is hard to protocolize obesity care. It's hard to protocolize everything 100% in clinical medicine, but I feel like obesity care is one of those things that just needs to be flexible and it needs to be adaptable. And Calibrate has created this program that really helps with employee populations. Our goal is to really help employers figure out that balance on how to provide this very, very necessary care for the members who need it, but do it in a way that emphasizes responsible stewardship and gives every member that wraparound support that they really need to be successful. I started this whole journey of mine in the bariatric surgery space. There's so many parallels here, because
Yes,
we know with bariatric surgery, it's an amazing tool. I'm a huge advocate of bariatric surgery. But without the wraparound support for bariatric surgery, same issue, right? The GLP-1s are no different. Great tool, super powerful tool. I love that we have it. But there's a lot that comes along with it that you really need for the outcomes.
Yeah, and I'm really glad we're talking about the wraparound. I'm a bit of a behavior change guy. We'll get into kind of where health literacy fits into all of this. There's, as you say, so much going on in the GLP space. There's been an acknowledgement that weight management is an issue, that diabetes epidemic, heart disease, et cetera. It's a big piece of the risk factors. Been a big challenge for employers. GLPs could be a tremendous answer, but kind of like bariatric, people are trying to figure out what's the total package. There's some talk about how people are using GLPs in kind of a short term. Oh, I'll just lose 30 pounds, then I'll go off, or I'll do it for a while, or what's the maintenance? What, is it a lifetime medication? All these questions around it. And ultimately, the behavior change, the lifestyle piece of it. So I'm wondering what's your point of view on that wraparound, on the behavioral side, on people's attitudes towards how to use these medications?
It's so interesting, because like we were talking about, it's such a dynamic space. And I feel like the pitch to employers has really varied over the past few years. Initially it was like, oh, we're going to get GLP-1s to your population, but we're going to yank the rug out from under them as quickly as possible,
Right.
just get them off the medication, in spite of the fact that all of the long-term data that we have seems to show that you will need medication to maintain the results.
So am I hearing you correct to say that for most members, that kind of have been qualified, so to speak, for this, it's a lifetime medication?
I will say certainly for individuals who are at very high metabolic risk, who have high risk obesity. Like let's say they've had bariatric surgery before and that surgery didn't work for them and they experienced weight regain. Or let's say they have complex metabolic disease like type 2 diabetes with end organ dysfunction, like diabetic eye disease or kidney disease or heart disease. Those individuals are very high risk. And I certainly think that long-term GLP-1 therapy is something that is going to be a reality for those individuals. I have had patients on GLP-1 therapy for a period of time. If they express desire to go off, if they lose coverage, that's been a big problem. And we can switch to something lower cost that they can take over the longer term that works for them and their weight is stable, as long as they maintain the metabolic improvements. That's what we're really looking for. And when that is threatened or at risk, my feeling is we want to be aggressive again with those members. We want to make sure that the outcomes really stick. And to your point about behavior change, the way we think about things at Calibrate is the medicine is one of the things that helps to set the biological conditions so that the body can begin losing weight. Because people who have obesity, we know, are stuck in mechanisms where fat storage is more ingrained. But having said that, so the 4 other pillars that are very important, of course, are nutrition. And that's particularly important because of the way these drugs work. Activity, of course, and stress management and sleep. Because all of those 4 pillars are very, very important components of behavior that will drive long-term durability of the weight loss.
Now there are different vehicles besides injections. Maybe there'll be a pill form, maybe there'll be longer lasting, shorter lasting. I was in this conversation with another professional who is also in the space, and we were talking about this almost likened to statins or something like that, where if you have a metabolic issue, just like you might have cholesterol issue or something like that, you take a medication. What's the issue? Other than right now, GLPs are very expensive and it's still refined the vehicle for use. But where do you see the actual medication going? Do you think we're going to get to a point where it's kind of like a statin?
My strong feeling is that they're here to stay. As a class, last I checked, I think we've got like 80 new compounds in the same class that are in the pipeline right now. Everybody is trying to produce what they can. The indications are expanding. And you're right, we already have 2 oral options for patients. We have an oral option from Novo. We have an oral option from Lilly. And my feeling is that that's going to really expand uptake overall. But one thing I want to call out, and this pertains to something that you just said, we talked about obesity is a chronic disease, just like high cholesterol is, so you need to take medicine for it. But having said that, if you have high cholesterol and you improve your diet, you go on a Mediterranean diet or cut out fat and sugar, you can have dramatic lipid improvements, even if you're not on medications. For those who don't have some genetic disorder, type 2 diabetes, same thing. I mean, you reduce sugar in the diet, your blood sugars are going to come down. You're going to need less insulin. You'll need less medication. So I think the biology and the behavior are always going to go hand in hand in metabolic disease. Salt and blood pressure is another prominent example. So I don't see obesity as any different in that regard. I think where we have failed in the medical community and as a society is basically labeling obesity as a lifestyle problem and saying you just need to eat less and exercise more and it's all going to go away. That's not true for high blood pressure. That's not true for diabetes. I mean, lifestyle is important, but the biological and the physiological therapeutic is critical.
You know, I was thinking about this the other day. We'll call it the obesity epidemic. A lot of people correlate food supply and lifestyle with increased obesity, and implying that if we just change those things, either systematically or at the individual level, we would be back to some much lower baseline of people with obesity. And yet it feels like we're taking a huge medical approach to perhaps, like you say, in many cases, maybe a lifestyle or more of a systemic thing. What's your take on where we medicalize maybe a lifestyle issue, or in some cases it's truly an organic biological issue, like you say?
It's tricky, right? Because the way I see it is any metabolic disease that you might have, it has a complex set of causes and contributing factors. We know there's genetics. To your point, the environment is a very, very strong component. We know that individuals who live in food deserts, who don't have safe areas to walk and get exercise, who live in areas where there is more pollution, they're going to be far more prone and more vulnerable to having metabolic disease. Now, I think if we suddenly just eliminated processed food from the world and put a treadmill in everybody's house, is that going to solve the problem? Not necessarily, because I think what people need to understand is that once obesity develops, there are actually epigenetic changes that occur in individuals' genetic codes that are passed on to their children and make it more likely that that child will be affected by obesity as well. So it's almost like even in the perfect environment, if you start off genetically susceptible, you're going to have a harder time. And so it just points to the need to really address obesity in a very comprehensive way, not excluding any one thing as an important causational factor, but really looking at the totality of what that individual is exposed to, what they have been exposed to. Not to mention, too, there are so many drugs that we prescribe for people in medicine that cause weight gain, from antidepressant medicines to type 2 diabetes medicines. I mean, so in a sense, we also create and contribute to part of the problem as doctors.
You're quite right to say that it's complex. And that's maybe where we get to this idea of health literacy, or how people understand the world in a broader context, right? And to distill all this information, people want a simple explanation. And in many ways, we've been doing some victim blaming here and saying, oh, it's their fault for having this metabolic condition and being overweight, and they have no self-control and all those issues. And I hope many of us have come to understand it's much more complicated than that. I wonder whether the patients or the clients that you work with, how well are they understanding this issue? So for me, health literacy is this idea that both at the organizational level, an organization explains health and medical information in a very understandable way, relevant culturally, individually, et cetera. But for individuals, they then have the knowledge, skills, and resources and confidence to navigate their own health journey. Where do you see us in our ability to explain this complicated things? People don't like a long story, Linda. They don't want to hear it's complicated. They just want to take the pill. And they don't want to hear they have to even do anything else but that. So talk to me a little bit about our kind of health literacy, our understanding of this.
I actually think it's surprising how many people we find actually have a sense of that, at least. They may not know exactly what they need to eat or what type of a strength training routine to do or how much cardio they need exactly for their body to maintain health and weight. But I feel like people definitely are coming around to this idea that you really have to change your relationship with not just food, but your activities and the way you work, the way you commute, the way you cook, the way you shop. At Calibrate, what we do is really through the emphasis in both the curriculum and in the coaching on all of these different things, right? And I think it's also about empowering people rather than just kind of lecturing to, try to get somebody to understand something. Also empowering people to seek out the information that they need that's relevant to them and their particular situation is important. What was kind of surprising to me when I first joined the company and learned more about the curriculum, unlike other places that I have been, we actually start here with coaching before the clinical visit. And that's something that's a bit different. It's not like we're saying like, oh, you can't have a drug. We're going to make you jump through these hoops. It's not like that at all. But what it is setting up that expectation on the part of the member that, hey, we're going to be together through this for the long haul beyond writing that prescription. There's a real partnership here, and that's how we're going to navigate this together.
I'm so glad you brought up coaching because that has a lot of connotations to people as well. I'm talking about buyers. Maybe individuals don't know what coaching is or understand it. There are many different takes on it. I'm a behavior change guy. I've spent kind of a career in lifestyle management space, if you want to call it that. And, I have my own book on well-being with a big behavior change chapter. And a lot of this also comes down to the behavioral science of what we're doing. I really liked your pillars of nutrition and activity, stress and sleep, all kinds of models around well-being, but, capture the key ones and have your coach work with you. There's a lot of discussion too about ultimately the motivation, the getting aligned with purpose and values and why bother other than, I want to look better or what have you. Whether it's Calibrate or I know you've worked with other organizations in the kind of behavior change space, talk a little bit about, best practices for this.
What it comes down to is that in order to really effectively change behavior, you have to get to know that person as an individual. Everyone has their own unique goals, wants, needs, desires. And so throwing sort of like a blanket, one size fits all type approach out there is typically not very effective. And so I think individualizing therapy, creating that sense of a therapeutic partnership, and giving individuals options on what is the best way for them to affect and reinforce change is really critical. And one of the things that I actually work on right now are some studies that look at the role of different types of accountability foci, if you will, and how those affect a member's overall progress on a weight loss journey. And I can just say at a high level, what we're finding is that giving individuals a choice of how and what to track tends to improve the way that they do overall with their program.
Give an example. What do you mean? Like within what they eat or?
When we think about a weight loss program and tracking, what comes to mind? It's usually you got to write down your weight. For some people, it can be a little triggering, especially if you've been struggling with obesity for a long time. And every time you go to the doctor's office, you have to stand there in the hallway with all these people looking and you get on the scale. And it can feel very hurtful and can leave people feeling full of shame. And so they may not want to track weight. So why not give the option to track, for example, your energy levels? Why not give people the option to also track sleep, for example? We find that when members do these things, is it directly related to pounds lost? No, not exactly. But there's a halo effect, we feel that really comes from just that enhanced awareness. And when people start to correlate things like, okay, I'm sleeping better, I'm feeling more motivated, I made better food choices today, that's like a light bulb moment, I
I
think.
really like this approach. For years and years, when I was involved with lifestyle coaching, the number one choice people wanted to do was weight loss, weight management. And then some years ago, it shifted to I want more energy and better sleep. And so the idea was we'll go with what people want. And of course, to your point, it's all connected. And okay, if I'm feeling like I'm sleeping better, I wonder if it had anything to do with how I'm eating or that I was a little more active today or what have you. The scale is the scale, and maybe I'll jump on it or not, but I know I'm feeling better and I feel like it's happening. So,
Right. Or I know my clothes fit differently. And it's interesting too, because like when you look at different generations, Gen Zers, they're less worried about having a heart attack 40 years from now, but they're really interested in how they function, like how alert they feel, how engaged they feel at work, energy levels. All of that is very, very important.
yeah, I've talked to so many people I know that have gone gluten free, and that's a huge
Yeah.
conversation. But
Right.
many of them said, I felt really sleepy after I kind of made that connection. And now that I don't do that, I'm not so sleepy. Now, it may be that they were eating huge sandwiches and now they're eating salads. And so there's something there. But the
Sure.
point is that people are making connections, as you say. And then that's very self rewarding, self motivating, self fulfilling. And it's more short term in nature than I'm not going to drop dead from heart disease or something.
Exactly.
You alluded to some research study that maybe by the time we post this has come out, but can you give us a taste of what some of your findings are? You were doing some subpopulation analyses and maybe finding some interesting differences.
One of the things that we're really excited about is our 4-year contiguous weight loss data. Very difficult to get long-term data on weight loss, particularly with GLP-1 medications, because the adherence really to a trial is very, very challenging. You have so many people who drop off, for a variety of reasons. So we'll be publishing 4-year outcomes data, subdividing that population. So highest risk types of members, right? So individuals who start with a BMI of greater than 40, even though BMI is a weak correlator of overall health, but it's like what we have right now, right?
Exactly.
So
Yeah.
individuals with a higher BMI, individuals who may have taken GLP-1 medications before coming to the program, who stop, regain weight, and then get on them. This is a population we know very little about. We have almost no data in the literature about how to treat these people, how to deal with possible metabolic, as well as honestly kind of like emotional resistance
Mhm.
to further weight loss programs. I mean, you're going to feel a little more jaded. Like, I did this already, it didn't work.
Mhm.
Why do I think this is going to be any better? So we call those individuals prior utilizers. So that's something that we've dug into quite a bit. And also looking at ability of our program to affect weight loss in different types of industries. So high physicality professions are definitely different from the desk-bound, high mental stress types
Mhm.
of industries versus those who have a higher propensity for emotional burnout. So like teachers, caregiving, healthcare, all of
Mhm.
those. That kind of breakdown is something that we're also really interested in, and we're going to be really excited to be talking more about.
I think your prior utilizers, that population is going to grow
Oh,
because I
yeah.
think a lot of people are try it or don't, or they go on just the commercial site.
Right.
That's going to be fascinating, Linda. I'm really looking forward to it. Is there anything that we missed that you want to touch on or at least emphasize then, if not, before we close out?
What I want to emphasize is the role of comprehensive support in being able to achieve the goals that you want as an individual or, for employers, for your member population. I think for too long, people have felt really sort of like isolated and they had to tough things out on their own, or feel like they had to starve or eat next to nothing and just deal with a lot of shame and blame and frustration. But I think now that we have so many more resources to offer, we're learning about how we can help people do better and augment outcomes of GLP-1 medications. Because in the real world, like the data has kind of been so-so, when you compare them to the clinical trials, but learning more about how we augment those outcomes through lifestyle change and strong support, to me is encouraging. And I think it's really exciting, especially as adoption of these drugs grows and expands.
I really appreciate that's perfect close. So thank you again, Linda. It's just really enlightening to hear you speak about this issue. Really appreciate the work you do. Thank you, everyone, for listening today, and take care.
Thank you so much.